Hello, my name is Justin Cromlow, and I'm the CEO and founder of OPOS. And this afternoon, we're going to spend some time with one of our customers, Dr. Joseph Dunn, and he's going to tell us about his practice. Dr. Dunn, can you introduce yourself and tell us about your practice?
Yes, my practice is in Eugene, Oregon, so it's a small town. I don't know, around 350,000 people between Springfield and Eugene. And I'm a solo practitioner. I was always part of a small group for the last couple of decades. And I came from the academic world. I came from UCSD as the fellowship director about 25 years ago. Came up here to actually work in the trenches, and that's what I did. And in doing so, I developed a comprehensive pain management clinic with several partners. This included interventional pain management, which has changed, as we all know, throughout the decades. And I also provide comprehensive care where I do a lot of evaluation and referral to specialists. And I do med management, and I keep track of the resources in town to provide the other types of care, cognitive behavioral therapy, alternative health care, physical therapy. And so it kind of encompasses all of the things that you do in pain management. It's just done I like to call it a piecemeal way. And in this practice, I'd say that I've noticed that when I first started, everybody was writing opiates in the 90s, and then this really took a downturn in around 2015, and has gotten to the point in this town where there are very few people who write opiates for their patients. In fact, there's an interventional pain clinic in town that doesn't write opiates for their pain patients. What they do is they provide consultation, recommendations, and they provide procedural care. So I'm still one of the only people who actually provide the total care. I also have about 200 spinal morphine and baclofen pumps that I still manage, but I've slowed that down some too as well.
Dr. Dunn, how many patients do you see in your practice?
Well, I have I have a physician assistant with me, and we're close to about 700 to 900 patients in the practice. Me personally, I see about 15 to 20 patients on a day, and then with OPOS I add another 30, and then with Marissa, who I've mentored into the OPOS program, she also does the same thing. So the two of us are seeing roughly 15 to 20 patients a day, plus OPOS 3 times a week, which is another 30 to 35 patients a day.
Can you tell viewers what challenges led you to seek out a solution like OPOS?
At the time, there's this huge decrease in the number of providers who would write for these medications. And most of the time, people would be writing the medications every 3 months. The other thing that happened is that interventional pain management became more and more prevalent in what we're doing, and medication management became less and less attractive in the practice setting. I think that there was a lot of fear based upon the CDC guidelines that, you could be held to a certain standard of care that you couldn't really afford to keep up, and therefore, it would put you at risk to get investigated by the board. And that's what happened, is a lot of people just, either became afraid or actually did get investigated by the board for not following the CDC guidelines, which were meant to actually be recommendations and talking points for physicians and patients, and they actually became accessed by the different regulatory bodies, and they started to be used as controlling standard of care. Because of that, a lot of people didn't want to write these things. I always wanted to write them because I think that if you're going to provide pain management, it should be a comprehensive pain management approach. That's my feeling. And so I didn't want to give up writing opiates. And so I was ready to try many things. And this kind of came about, through a phone call from an old professor of mine. And he asked me if I would be interested in looking at it. And I said, sure, why not? And so I jumped in. And the first thing that we did was we started providing educational visits to my patients who would get monthly educational visits. And all of a sudden, for the first time, I actually started having, cognitive behavioral therapies available for patients where before, if I was trying to get a cognitive behavioral therapy regimen, I'd have to just kind of send them out to some, psychologist out in the community. And I always thought of it like a black box where they go into the psychology treatment plan and then come out, and whatever came out, that's what I got back. With the OPOS, I actually had some control. I actually got to listen to the OPOS providers give their topics. And then the other very interesting thing is my patients all of a sudden they liked it. And I mean, that's going on 2.5 years. They all like it. They all like to learn about what's happening. And I tell them, I say, the way it's done in OPOS, they kind of treat these people like little pain fellows. And by the time these people have gone through, 15 to 30 topics, they all come out knowing as much, maybe more, than some pain docs out there, which is really valuable. And the topics change because there are very skilled practitioners who are giving those topics out.
So Dr. Dunn, as you are considering OPOS, as you were looking at OPOS, what other options did you look at? What other tools did you feel that were available to you to help manage your perception of risk related to the opioids that were being written in the practice?
Well, most of it I had to do on my own. I had to read those guidelines multiple times. I had to set up little templates within my electronic medical record. I had to have a scribe who'd help me keep track of these things, and I would just write a narrative of prescribing these meds. And it actually, what I had to do finally is I couldn't take any more patients because I couldn't. How many patients can you safely document and practice with? That was one of the big questions I had. And then the other thing you had to make choices. You only have so much time. So do you want to provide opiate management, or do you want to spend more time filtering through patients to develop plans that included interventional pain management, which makes your practice very sustainable at this point? And so I think that's what I focused on, and I found that I really had to continue to balance that. That was my ongoing challenge. And then the other thing I knew from years of practice was that I learned that if you kept your pain patients, but that they provided a kind of a stable of people who needed procedures, if you were good and you cared for them, that actually would allow you to do procedures on people for years. And I have patients in my practice who I've been doing procedures on for decades. It's management. It's not pain treatment and fix. It's pain management. And so they're going to need things as they change. And so that was also part of my practice at the time. And I was okay with it. But I have to tell you, it changed quite a bit when I started doing the OPOS.
And so, Dr. Dunn, to also think about the beginning, can you describe what your experience was like getting started with OPOS?
When you first started, I found it very easy to do. It was just a matter of getting, my patients enrolled through the application online so that they could start getting their educational visits. And a little bit more of the challenge came in when I started getting the patients to make their appointments for refill management. And initially, I started my patients still refilling them every 3 months, but requiring that they get education every month. And eventually, along with the CDC guidelines and everything that happened, I actually went to prescribing monthly.
So Dr. Dunn, did OPOS give you an 800 number and a bunch of software and tell you to just kind of get it going and say good luck to you? Or what was the initial experience like for you and your staff, both the clinical staff and the administrative staff?
So when we first started to get OPOS rolling in the clinic, we developed a brochure with one of the patient educators on that brochure, and it had some numbers that the patient could call. And I also learned how to use the OPOS Foresight app, which is pretty intuitive. And we went from patients not knowing how to use the app to patients calling and pretty much getting the technical support they needed to get the educational portions started and going on a monthly basis. We also taught them how to use the metrics in the OPOS Foresight app that allow them to, get some data to show that there's, benefits and what their side effects and risks are. So we have an ongoing tracking system now where I could actually look and be able to document the benefits that the patient was having and also at the risks that they had and that they understood the risks. And so when the CDC guidelines came out, they basically identified the risk, but they really did not identify the benefits.
And can you kind of fast forward that to today and talk about what the practice is like and what ultimate decisions those providers made and what's happening in your practice today across all the patients?
I had the opportunity to just kind of mold my practice around doing medication management and interventional management. And with using the OPOS platform, I was able to take a lot of the patients that I was seeing and writing opiates for and make it a very short visit for many people at the same time. And all of a sudden, my clinic, when I saw patients on a regular basis, opened up to being able to see patients who needed evaluation and interventional treatment. So now when I see patients, I probably get a procedure for every patient I see in the office. And then on my OPOS visits, I see, about 30 patients or 35 patients at a time, and they need med management. And they also have a chance to get triaged during the breakout sessions after the shared medical appointments. And they get their opiates and they spend a small amount of time getting on the OPOS app and getting on the shared medical appointment. And it usually takes me about an hour to an hour and 15 minutes to do that, and I have the rest of the time to see patients. So, and what was really interesting too is as I did this, I was able to, train my physician assistant who now totally buys into OPOS. And she has 2 OPOS clinics a week. And so not only did my volume of patient visits go up, but the level of acuity went up, the number of educational visits went up, and the number of procedures that I do went up. And so I was pretty amazed, actually. Would have been happy with, 1 or 2 of those things happening. I got all 3. And so that's, probably why I'm on this, platform talking to people, because I think this works. I think that it also provides access for people who actually benefit from opiates.
You are pretty much the only practice that is willing to write opioids for patients with chronic pain, and you lost 2 providers. And so rather than essentially look at a practice that only serves 1/3 of the community it used to, you're actually saying that you are serving a greater part of the community than you did when you were 3 providers.
It's allowed me to, tailor my practice in a way that I can pick and choose people who know how to be safe with the opiates. I could pick and choose patients who want to use interventional pain management as part of their management therapy plan. And so that's my group of people who I currently have, and it's an extremely sustainable practice that way. And I also have an incredible reputation out there right now in my community. They, there's no one who is questioning me providing opiate management to any of my patients. But I do stay within those guidelines, but OPOS makes it easy to stay within those guidelines, and it helps you stratify those people into different risk groups. And you can kind of see, what you want to do with the different risk groups. Like occasionally I'll take a couple out of the, higher risk group, and I'll just manage them because that's what I know how to do. But I don't have to fill up my practice with those people and suck the resources out of my clinic to do it. I just pick some to take care of a few, and then I actually gear my practice towards the people who need the combination of opiate management and interventional management.
You're getting data that's been collected every day on the patient in the 30 days that they're not with you. All that data is being risk stratified. And so what you were just describing to everybody now is that the complex patients that need a higher level of care that will demand more of your time in order to get the benefits that you're hoping they receive from a functional perspective. But at the same time, you have the confidence in the low-risk patients that they are low risk because you meet with them each month, but you don't have to spend as much time with them because you have so much data that reinforces and that demonstrates that they're low risk. So you're basically validating what you're being told. And if the patient wants to share more information, you can, but you don't walk into a room anymore not understanding what you may be facing with the patient. So you're able to reorganize how you spend your time and know where you want to put the time. And so it's more of kind of an upfront and way rather than starting at the beginning of your day with 30 patients or 20 patients you're going to see and trying to hopefully make it out, some reasonable time near dinner, but each time you walk into a room, you don't know what you're facing.
So there's several thoughts that came up when you said that. One of the thoughts is that, these patients, they've been kind of marginalized for so long. And they tell me they tell me I don't really have a problem with staying on my opiates the way they're prescribed, being compliant, doing the education. I can tell you how it helps me. I'm not getting high. I'd never take these things if I didn't have chronic pain and so on. We all have a sense of those people who are clinically appropriate for opiate management. But to actually be able to, set up a group of those patients and monitor them and get their functional capacity and get their functional improvement, and also see from a risk standpoint that they do follow all the safety guidelines that are in place for them to show that they can manage these things safely. And when I first started practicing, your risk of opiate use disorder events was something like 1 in 5, 1 in 5 patients, 20%. It went down some and it went up some. But, with this platform, you may find that your risk is like 1 in 10,000. It's just the data's got to be collected. And that's one of the big things. I have to tell you, my patients love that because they love being part of a group that's validated. They're no longer like the marginalized people. And when they go to have surgeries for their orthopedic surgeries or their general surgeries and the surgeons call and the primary care docs call, we go over this with them. And I have yet to have a community, physician say, "Oh, I disagree with this." They're all like, oh, "I'm so glad this is happening." And yeah, what can I do? And so now I get buy-in from, my referral basis. And so then it makes it easier to get referrals because you have to be careful because they like to give you those tough ones, but but you can also, now you have a way of taking on some tough ones and kind of putting them through the compliance checkpoints. And if they don't, if they can't do it, then they may not be the right person for your practice at this point. But you can see that over time, it could really get bigger to where you could take on a few of the really challenging patients with the appropriate resources. But right now, it's just finding that group of people who actually do not have that huge of a problem with opiates and opiate abuse events so that you can actually validate the safety and the efficacy of these drugs. To me, that's huge. I've really enjoyed doing that in this last part of my practice. I've been practicing for over 25 years. And so, this is a nice way to go out. That doesn't mean I'm going out soon, by the way. I think I'll be sticking around for about 5 more years. But saying all that, the challenge is going to, to me, is going to be finding people who want to do this and getting these practices set up throughout the country so we get enough data to show what I'm talking about.
So, Dr. Dunn, from your perspective, so you mentioned that you're kind of towards the end of your career. So if we look at it from an experiential perspective, you have, now more experience and more varied experience than you've ever had from when you first became a pain specialist. So kind of thinking about it from that perspective, what are some of the most meaningful results you've seen so far among your patients?
I think, one of the things that I really knew all along and I've been able to show is that you don't need that much time to manage your patients in a shared medical visit. You still have to put in the time to get all the outcome measures. You still have to do the triaging. You still have to, work them up for their other non-opiate related needs for their ongoing pain management. But all of a sudden, you have a way to really find those patients who need you and just, keep the other ones well monitored and well accepted within the community. And so all of a sudden, you have this, you have a practice that is really looked upon as a way to take care of pain patients. And I really enjoy that part of it. And I think, the other thing too is I've always had a hard time getting cognitive behavioral therapy to my patients because it's so fragmented and the psychologists who provide it come and go, and they all have their bent on what cognitive behavioral therapies they think the patient needs. And here I can say that all my opiate patients are getting cognitive behavioral therapy. They're all getting it, and I know what they're getting. And so now my patients they're getting med management, they're getting evaluation and referrals, they're getting interventional management. I know people in town now that I actually have time now to go out and talk with the physical therapist so they get a decent reconditioning program, and I can monitor that through the OPOS app. It's a way to practice comprehensive pain management that I haven't been able to do in the past.
Well, Dr. Dunn, so as we look out kind of towards the future, what do you think about your ongoing relationship with the OPOS team?
Well, pretty easy to work with overall. I've had a good experience with the technical people, with the people in the Zoom meetings, with the people, in the leadership positions. They're accessible and responsive. Every issue I've had gets addressed. It's fair. If you pay attention to detail, you can get reimbursed for the educational visits, for the high level monitoring visits. You are, with the information you get, you can stratify your patients into risk groups. Sometimes what I'll do is I'll call the OPOS folks myself. I'll say, I get online with the patient. The patient says, I can't do this, I can't do that. So I just pick up the phone and, get the app up and pull up the number on the app and talk to a person. And it doesn't matter at what level they are, it always gets back up to the level that needs to be addressed. And that's the beauty of this, of the platform right now.
Well, I can tell you, Dr. Dunn, that will never change. We're always about patients and their providers. And it's going to be humans that create the connection and maintain the connection, not AI, not technology. And I think that's a really important piece, because I tend to think that irrespective of whether you're in Eugene, Oregon, where you are, or you're in a big metropolitan area, the relationship you have with your patient and that the patient has with you is probably very similar. They rely on you for their quality of life and to help them stay functional. And you mentioned that many of the relationships that you have with your patients have gone on for quite some time, for decades. They've relied on you. And so what's the one thing, if you had to pick one thing about OPOS that really exceeded your expectations, what would that be?
Access to care. It's really shown that we're going to be able to keep access to opiates, to me. That opiates have a place. They may not have been as widely used as they were, 20 years ago, but they definitely have a place. And now you actually have a chance to figure out what groups of people actually benefit from it. And I think that's a huge piece of this whole thing at this point.